to sort of continue these webinars going forward. But today's webinar is really sort of thoughts from ESC. So for all of those that were working hard while everybody went off to ESC and had a jolly and weren't able to catch up with all the new sort of studies and research, we felt that actually let's put together a webinar really to sort of highlight the various aspects of it. So that's today's theme. We've got three great speakers from different aspects, from nursing, pharmacy, and also for the medical, sort of doctor side. So we're going to start off. The talks are going to be about 10 to 12 minutes. No questions. I'm going to run the talks through, and then we're going to have sort of Q&A at the end. If you have got a question or anything you'd like to bring up, can you please put it in the chat, and I'm going to I'll look at the questions and try and bring them up. If you want to hear your voice and you want to actually ask a question directly, I'm very happy, at the end, stick your hand up, and I'll try and pull you in as well. And actually, let's make it a bit of an interactive session as well. I'm keen to finish sort of on the dot of 8 o'clock. I know everybody's got busy lives and probably sort of wants to have a glass of wine as well. So I'm going to hand over to Becky to kick us off. She'll introduce herself and start her talk. Okay, so Becky, over to you. Do you want to share your screen?
So hi everyone, I'm just going to share my screen with my presentation. Okay. Is that coming up okay for everybody?
Yep, that's great. We can see that.
Great. Okay, so hi everybody. Thanks to the BSH for asking me to talk today. So we were asked to talk about our highlights from the ESC Congress. So I'm talking about comorbidities and optimizing care through collaboration. So here are my disclosures. So this was my first actual ESC Congress, and I was struck by how big the event was. There was so much to see and lots to take in, and great opportunity to network with people. And when I was asked to talk at this webinar, trying to think about what my message would be, it struck me that a lot of the talks were about managing comorbidities within our patient population. So I'm going to talk a little bit about atrial fibrillation and hypertension, a bit about iron deficiency, a bit about cardiac and kidney disease, and then to end on collaboration and the MDT. So I attended a symposium about the early detection of atrial fibrillation, and part of that talk really struck with me, which was this vicious cycle that we see that atrial fibrillation and hypertension often promote each other and are stuck in this vicious cycle that often leads to cardiac dysfunction. Patients are often asymptomatic with atrial fibrillation and or hypertension for a long time. And so often these risks to their heart health are laid undetected for a number of time. Actually, it was interesting to hear that 70% of patients in atrial fibrillation studies also have hypertension as a comorbidity. And the same can be said from the hypertension side. Many of those have atrial fibrillation. And if patients are unaware of these underlying conditions, they're not being managed properly for them. So their risks of stroke and cardiovascular disease are not being managed. And so really the takeaway message from this session really was about that systematic screening of patients that come into our heart failure clinics with either atrial fibrillation or hypertension, to just consider whether they have the other, and so we can manage these risk factors early and prevent unnecessary cardiac dysfunction. So the next sort of programme that I found really interesting was sort of the updates regarding iron deficiency and cardiovascular disease. I went to a talk called What Have We Learned So Far? And I really liked this infographic, which showed sort of the prevalence of iron deficiency, particularly in the HFrEF population, the outcomes for the studies, what it means when they have iron deficiency. There's an increase in mortality and hospitalisation with a reduction in quality of life and functional status. And the fact that if you treat with iron, intravenous iron, you can really improve their quality of life. You can reduce their hospital admissions and reduce their symptoms. So that's led to updates in the 2023 update of the guidance, suggesting that we should give intravenous iron to those with HFrEF and HFMREF who are found to be iron deficient, because it alleviates their symptoms and improves their quality of life. And also there is some evidence to suggest that it reduces hospitalizations. So the next comorbidity that I found sort of lots of interesting talks about was the interplay between cardiac and kidney disease. So there are often common risk factors between patients who have kidney disease and cardiac disease: age, hypertension, obesity, diabetes. And the biological pathways are very similar, with the activation of neurohormonal pathways and inflammation, which often means then that you get this overlapping of clinical presentations, so that the symptoms are very similar. And what that means then is actually, if you can find medications that support both comorbidities, then that's benefit for the patients, because you just have that sort of concordant benefit. So one agent that's being looked at is finerenone. Now, I will admit here and today that I'm not an expert in this field, but you know, the overactivation of the mineralocorticosteroid receptors leads to inflammation and fibrosis of the heart and kidneys. And it's been found that finerenone, which is a selective non-steroidal MRA, can really reduce the impact of that overstimulation. There's been some studies in the CKD field that suggests that we should be giving it to patients with type 2 diabetes and CKD. And there are now studies looking at finerenone, particularly in the heart failure population, which my colleague Vicky will talk more about in her presentation. And as well as the finerenone, we also have the SGLT2 inhibitors. So, of course, we've got the updates that patients with ejection fractions greater than 40%, SGLT2 inhibitors are now advocated to be used. But also the data from the DAPA CKD and EMPA kidney studies have also shown that using SGLT2 inhibitors in patients with kidney disease and diabetes can reduce cardiovascular death and hospitalization due to heart failure. So again, the data has now been added into the updated guidelines, so that we recommend that we use empagliflozin or dapagliflozin for these patient groups. And then thinking about collaboration. So during the ESC, they had some great posters looking at the optimization of heart failure medications, particularly as a nurse in the nurse-led optimization clinics. And there's a real messaging through the talks about how we should really be collaborative in our approach. I watched a really good presentation by Carolyn Lamb, Cara Spartan, Mark Petrie, and others, talking about how we should work as a multidisciplinary team to optimize the guideline-directed medical therapy. It's clear that there's lots to do with HFpEF, often to do with teams not commissioned to look after patients with HFpEF. But now with using SGLT2 inhibitors in this patient group, it's clear that we need to make sure these patients are brought into our heart failure services so that we can optimize their therapy quickly and in a timely manner. And it's really important to have early diagnosis of heart failure. There's variation across the nations, but it's clear that with all the comorbidities, the earlier we detect heart failure, the earlier we can put in place the medication that can optimize and reduce their burden. And really the message was, the wider the MDT, the better. We really, the more we work together and collaborate, we can ensure that patients with heart failure are managed appropriately, but also we can support patients with the comorbidities to prevent having heart failure in the first place. There are my references. Thanks very much.
Thank you, Becky, for that update. Just to reiterate, what we're going to do is do questions at the end. So I think there are some interesting, and I've definitely got some questions that I would like to ask, and I think we should discuss. So I'd like to again say thank you, Becky, for pulling that together. I'm now going to move on to Vicky, who will introduce herself. She's a pharmacist, and we've worked together before on various things, and I'm looking forward to seeing what her highlights of the ESC were.
Thanks, Simon. So as he said, I'm a pharmacist. I work down in Bristol. I run MedSop clinics and work as part of our MDT, so going on the collaboration that Becky just highlighted. And predictably, as a pharmacist, I'm going to talk about drugs today because that's pretty much the only thing I know. So let me just share my screen and then I can give you my highlights. Like Becky, there are many choices of things that you can go to. Oh, let's not give away everything. So here we go. So like Becky, they're on, ESC is not to be underestimated, frankly. It is huge, and there are lots and lots of choices. And actually, I made some quite interesting ones accidentally. I've got loads of disclosures. I've probably got more than everyone else. So I don't have any particular favourites because I work for everyone. I think my highlights, my real headlines were two big trials and then looking at what was coming next. So a lot of my work as a pharmacist is to make sure I know about drugs before the doctors do, because otherwise they will ask me for them and I'll get caught out. So the first big one, the real kind of big hitter was the STRONG-HF trial. So this was looking at acute heart failure and decompensated patients. And it was looking at getting in, really pulling in and getting into how quickly you could get things in. So this was within 2 weeks. The idea being that as soon as they got in, you initiated it. There is one thing to note, and STRONG-HF is really being quoted a lot now about how important it is to speed up our optimization, making sure that everyone's on pillared therapy, but actually in STRONG-HF they used 3-pillar therapy. The SGLT2s were not included in this. So this is our more classic 3 pillars of beta blocker, ACE or ARNI, and MRA. What you can see from the graphs, and I've kind of put them on there for you, is that the high intensity care had much better outcomes for either readmission for heart failure or all-cause death, and then they took it down even further, and this is at 180 days, so a not insignificant amount of time. We're looking at 6 months here, and the high intensity care also prevented all-cause death, so this was quite extreme. Now there are multiple graphs if you go and have a look at this trial. The ones that I put up here are the ones that excluded COVID-19 because unfortunately this was carried out in the height of the pandemic. Luckily, they had included a huge number of patients, so they could actually actively exclude those that were died due to COVID-19. But it does make the trial a little bit more dodgy. It's a sensitivity analysis rather than a primary endpoint because of that. I will say that the primary endpoint was met as well, and it was statistically significant. So regardless of COVID, it still showed the benefit. And it really just gives us that emphasis now to say, we need to be aiming high, we need to be going for 4-pillar therapy, and we need to be doing this really fast, and we can do it in acute patients as well. So a lot of our 4-pillar therapy we really think of as our chronics, but actually these were acutely unwell, decompensated patients that were offloaded and then titrated aggressively. So that was a big one for me. It kind of underpinned all the things that we're already doing. So certainly in my trust at North Bristol, my consultants are aggressive to the point of ridiculousness in some cases with their kind of initiation. They'll do de novo Entresto, which is, controversial, but was done in this trial as well. To allow it to be done in 2 weeks, and they do put in SGLT2s on everybody. So like Becky was saying, they've really got a place in therapy. It's just that they weren't around when this was designed. So I think this is something we should all be focused on really now, and this is something that I think has huge outcomes. When you look at that heart failure admission and all-cause death, that is an astronomical difference. That is really powerful. The next one, I actually didn't go to this trial. So this is STEP-HFpEF. And the reason that I heard about this trial is because within nanoseconds of it finishing, 3 different consultants all WhatsApped me to say, when can I have semaglutide, please? So I realised that a big trial had gone down and I was not in it. So I had to do some very fast reading. And this was looking at a GLP-1 agonist, semaglutide, 2.4 milligrams weekly, and the effect it had on quality of life and weight in the HFpEF population. Now, this ties into a lot of the trials and the kind of new science, translational science that was being presented at ESC, all about how inflammation is related to HFpEF as an independent cause for HFpEF. So taking aside all the comorbidities that we often associate with it, this was looking at inflammation in itself. It's semaglutide is made by Novo Nordisk, and my background, I should say, I was 12 years as a specialist pharmacist in diabetes, so I have been dealing with GLP-1 agonists since the day they were dawned, and so this is not a new thing for me. But what's quite interesting is looking at the trials. It's a very classic Novo trial. They're very clever in how they design it. They specify huge numbers of endpoints, which means they can pretty much draw whatever they want, and they had dual primary endpoints in this. So the dual primary endpoints were body weight and quality of life. They weren't looking at hard outcomes like readmission. They weren't looking at death. And if you think about it, in a HFpEF population, they aren't the easiest outcomes to meet, because these patients don't tend to be admitted as frequently, and they don't tend to die as quickly and easily as our HFrEF populations. So, you know, we're looking at a different kind of category here. And I think we're going to have to really start looking at how our populations compare, because, you know, we're drawing lots of assumptions into this. But one of the things about the secondary endpoints in this is they looked at things like reduction in BNP and CRP. So they were looking at the inflammatory processes, not just do people lose weight. You know, if you give people semaglutide, they will lose weight. We know that from the current GLP-1 craziness, where, you know, you've got all of the obesity, they're being licensed for obesity, type 2 diabetes and obesity and things like that. We know they're going to make people lose weight, but there are other trials. We've seen other trials before with lifestyle modification where people with HFpEF lost weight, and actually that did not prove particularly beneficial in an outcome setting. So there's something else going on here, and I think this is what the hint towards inflammatory process is in semaglutide, in that because the BNP and the CRP went down, they're drawing assumptions from this and saying that actually there's an inflammatory process involved in this. And I think there were lots of kind of tiny translational science studies that were going on that were all saying the same sort of thing. So I think this is something for the future, and it's something to keep an eye on. I will say, as I said to my 3 consultants that will text me, you can't have semaglutide at the moment. So the 2.4 milligram dose is Wegovy. This is the obesity dose. This is not Ozempic, which is the diabetes dose. None of these are available currently in the UK. There is a worldwide crisis in supply. There's a new kid on the block that's just been launched this week, tirzepatide, which is also undergoing heart failure trials. They are ongoing at the moment. So this is an area that is going to grow and grow and grow. So I would definitely recommend having a look at this one, because I think this is something that you'll keep seeing coming up. And this is very much something that we're going to need to share and be friends with the diabetes team to really work out how we're going to manage this. I'll talk briefly about the guidelines, because I think Simon's covering this. I think the real thing with the guideline medicine is that they firmed up the treatment pathways for the HFrEF and the HFpEFs. So they actually put in what medicines are expected to be used in these. Now, this is not anything new. It's nothing surprising, but it gives that kind of emphasis on what should we do when these patients turn up. And, you know, like Becky was saying about you know, who should be looking after things, collaboration, stuff like that. Having these kind of defined guidelines make our lives so much easier, because we really can just say, okay, this is what I should be doing and this is where I should be going. Should note, when you look at the HFrEF, that the evidence base isn't great for our favourite drugs compared to the Flozins and loop diuretics, but that isn't to say they should be ignored. And I think often in the HFrEF, HFpEF patients, you know, the comorbidities will override that and actually make them class 1A for diabetes, for kidney disease, for obesity, and so on and so forth. The future, I will touch on this very briefly because I've probably overrun already. There are lots of things coming. So I mentioned about inflammation. I've talked about immunity, so I haven't, you know, finerenone. So this is a picture of some of the, it's called the Moonraker program. It's very fancy, but it's some of the trials that are going on. There are actually something like 10 trials going on with lots of different things. At the moment, finerenone has a nice TA for use in diabetic kidney disease. So it is the MRA favourite for diabetic kidney disease. And if you look at the KDIGO guidelines, which are the renal drug guidelines, they have started to adopt the pillar idea. So they have added finerenone as one of their pillars alongside ACE inhibitors and SGLT2s. you'll note how similar it is to have an MRA, an ACE and an SGLT2 in a pillar therapy. So I think the world is converging somewhat with renal and heart failure from their recommendations, and finerenone I think is going to be the one that draws it across, because spiro and eplerenone, we often are much more terrified of putting those into our renal patients because of things like hyperkalemia and things like that. With finerenone, they're really showing the benefits, and because it has a different mode of action, it's a non-steroidal MRA, unlike spiro and eplerenone, it does have a different outcome and different effects. So I'd highly recommend looking at these trials. Not all of these are published. The first heart failure trial to be published on this is due next year, which is in HFpEF. The HFrEF trial isn't due until 2025, 2026. So there's a number of years of this that's still to come. And I think this will be next year's ESC is talking about where this fits. Other things that were coming up in the across the ESC, I didn't go to a lot of these, but they are coming. Things like immunomodulation. So these are using the MAB things, so canakinumab and secukinumab. These are currently licensed drugs for other inflammatory processes, but again, it's kind of going into immunomodulation and inflammation. Much more technical from a drug perspective, but we are probably going to have to get on board with these. Telemedicine was a big hit. There was loads of stuff about how you do medicines over the phone. And then AI Echo was the other one. So that's another big one that's coming in the future. But, you know, I will let cleverer people than me talk about echoes, because as a pharmacist, that is one thing that I will step away from, other than looking at it upside down going, definitely a ventricle. So in summary, embrace what's going on. Dive into new specialties. We're going to have to very much make friends with our renal and diabetes friends and start calling ourselves the CVRM team, I think. Keep chasing the knowledge, because there is so much of it out there, and have a look to the future, because it is going to be changing year on year. And I think we're on the middle of a very fast roller coaster. So that is it from me. So I will stop sharing my screen and hand over to someone else.
Thank you, Vicky. That was a great overview. And I think, like you say, it's going to raise some really interesting questions around how we move forwards. The chat is very quiet at the moment, so I'm hoping that people are just mulling over what difficult questions they want to ask us, or ask everybody. I'm now going to move on to Matt, and he's going to give his overview. He's crawled out of his deathbed, so we need to feel sympathetic for him, and if he coughs, I'll apologise for him. So over to Matt.
Thank you. I've just realised that my screen won't let me share for some reason, so if you just give me 2 seconds to rectify that. Simon, in case this doesn't work, can I email you my slides now?
Yes, you can email me the slides now.
Thank you. If everyone wants to grab a glass of water while I do that, would be useful. 1 second. If not, I'm happy to do it just by speaking, but it would be much better with the graphs up on screen.
So, Matt, if you send me yours, I'll get it up. And
that would be great. Thank you.
Yeah, just waiting for it to run. I think, yeah, Vicky stopped sharing, so I'm not sure why it's.
I think it may be that I'm a Apple Mac user. And it's not allowing. Yeah, I know. Sorry, everyone. Okay, Simon, it's popped into you. It may take a moment. It's quite a big set of slides.
While we're waiting, like I say, has anybody got any questions while we're waiting for us to set this up? Is there anything anybody would like to ask?
Simon, it's Patricia Campbell here.
Hi, Patricia. Hi.
It's brilliant so far, of course, as expected. And Matthew, don't worry, this happens to me every time I give a talk, so don't worry.
Brilliant.
But there is something wrong. I can't put anything even up in the chat, so maybe that's why it's a bit quiet.
Although.
Yeah, it just keeps saying something went wrong. Try again later. So I don't know.
Okay. Well, that's great. We can make it more interactive, because we can everybody can stick their hand up, which is it's far nicer to talk to people. So I can share.
Agreed.
Here we go. Right, I'm gonna be now.
Brilliant.
Can everybody see? Hang on a sec. Let it play. Come on. Can everybody see that?
Yeah,
Yes.
it's kind of on small version at the moment.
Is it not on? It's not on.
No, it might actually be better if you can just zoom in, Simon, because I very cleverly added 1,000 animations, which is going to be an absolute headache for you to try and sift through. So if you just sort of zoom into it on the screen, that might be best anyway, without playing the slideshow.
Okay, all right. What I'll do is I'll magnify it.
Brilliant, thank you.
Okay.
Amazing, that's fantastic.
Cool.
Thank you very much, Simon. Okay, so sorry for that, everyone. Thank you for your patience. My name's Matthew Stanley. I'm a heart failure senior fellow at the Royal Free Hospital, and it's a pleasure. It's my second ESC Congress. I think I'm getting better at navigating them each time I go, so hopefully next year I'll have even more to share. If you could skip to the next, please, Simon. I have no disclosures formally. However, if you pop onto the next slide, the one disclosure I would make is I have tried to squeeze in as much data as I could onto this, which might end up with me rushing through and simplifying quite complex papers. So what I would recommend is please do, if there's anything that you find interesting, please have a search online, go on PubMed and have a little look at the results yourself. I'll try and summarize the salient points as best as possible. Next slide, please. So first off, just tackling sort of arrhythmia and device therapy related to heart failure. Next slide. So the first study that was presented, the Castle HTX study. So this was based on off the back of the Castle AF study, which was published a couple of years ago, which proved in a certain cohort, which was quite a contentious cohort of quite young and heavily male patients, catheter ablation in those patients with symptomatic AF showed reduced mortality and reduced heart failure hospitalization with a hazard ratio of 0.62. But that kind of excluded transplant listed patients and end stage patients, and many of our patients are quite severely unwell. So Castle HTX enrolled just under 200 end stage heart failure patients, or at least on the transplant list for consideration, and compared medical therapy alone versus AF ablation and medical therapy. The inclusion criteria there: symptomatic AF, transplant candidates, severe LVSD, NYHA class over 2, and they had a device for monitoring as well to look at AF burden. And the primary outcome was a combined death from any cause, LVAD, or transplantation. And they planned to study this for 3 years. However, if we go on to the next slide, this was stopped after only 1 year. And if you look at the Kaplan-Meier graph there, you can see why. So a really early separation of the curves in favor of the ablation arm, with drastically increased death, transplantation, or LVAD in the medical therapy arm compared by sort of, it was 8% versus 30%, quite a drastic difference there, hazard ratio of 0.24. And then looking at the secondary outcomes that probably mean the most to us, all-cause mortality down at 6% in the ablation arm versus 20% in the medical therapy arm, and then urgent heart transplantation 1 versus 6%. So quite drastic outcome data there. If we just pop onto the next slide as well. This focuses on, something that we might have expected to see, and helps us maybe also looking at our sort of arrhythmogenic cardiomyopathy type patients, even in less sick cohort of patients. LVEF in the ablation arm sort of increased from a baseline average around 28% up to around 35%. We didn't see drastic increase in the medical therapy arm, and unsurprisingly, AF burden improved in the ablation arm. So conclusion of this, sort of my conclusions: AF ablation in this study reduced all-cause mortality and the need for advanced heart failure therapy, and it could even improve LV ejection fraction in even our end-stage heart failure patients. However, something to consider: heart failure MDTs should be utilised, or could be utilised, to consider patients suitable for referral for this. So I know that who's suitable and who isn't, and who should we be referring, is certainly a contentious topic among the heart failure and the CRM field. Next slide, please, Simon. So the next paper, Budapest CRT. So this is a big one you may have heard in heart failure MDTs or already being applied. It may have already been applied in the past before this data. So this is on the basis 30% of patients who have an ICD or a PVM, a permanent pacemaker, pacing in the right ventricle will develop LVSD due to right ventricular pacing, essentially. And that's been proven in previous studies. Budapest CRT upgrade investigated whether it was beneficial, and do we have the evidence to show that patients who've got severe LVSD and a previous ICD or pacemaker that are pacing in that right ventricle, do they get a benefit or is there harm from upgrading them to a CRT? So the patients they included, these are HFrEF patients with a previous pacemaker or ICD in situ, RV pacing above 20%, that was the cutoff, and with a broad paced QRS complex already optimized on GDMT. And they ruled out patients, importantly, with a left bundle branch block baseline morphology, because those patients would have an indication for CRT anyway with severe LVSD. They split the patients 3 to 2, and they looked at quite a complex endpoint of first heart failure hospitalization, all-cause mortality, and then a less than 15% reduction in LV end systolic volume, which is quite complex. We'll go into that in the next couple of slides. These were a very sick cohort, unfortunately disproportionately male, quite severe symptomatology, so almost 50% of class 3 and above NYHA symptoms, and almost 50% who'd had a recent or previous heart failure hospitalization. So this was not a well group of our patients. Next slide, please, Simon. And here's the data. I think if we look first on the left side of this graph, that's the 6-month data. So that's just a composite of all-cause mortality and heart failure hospitalization. And already we can see that there's a significant reduction in heart failure hospitalization in the CRT arm, and also a significant reduction in the all-cause mortality as well. Then at 12 months, when they factor in basically this measure of end systolic volume of the LV, again, there's a much bigger improvement in the LV end systolic volume, as well as an improvement of heart failure hospitalizations and mortality in this right hand, with really impressive results for that. But I think that's quite a difficult outcome to interpret. So if we pop into the next graph on the next page, please, Simon. I think this one's much more readily sort of digestible. So combined endpoint, heart failure hospitalization and mortality, with an early separation of the curves, the ICD arm doing far worse, approaching 31%, heart failure hospitalization or mortality down at 10% in the CRTD upgrade arm. So that's a number needed to treat of just under 5. And these findings were consistent across age, RV pacing burdens, LVEF at enrollment, and these other comorbidities. So really quite widespread and really consistent data. Next slide, please. And then possibly unsurprisingly to some, but actually if we think about it, these are not patients with a broad left bundle branch block. They were excluded, and even in the patients who did not, who had a narrow complex but were pacing heavily in that RV when they were pacing, with the CRTD given, we had an 11% average increase in LV ejection fraction compared to a minor, basically negligible change in the ICD group. So that's quite remarkable for LV remodeling as well. Next slide. So something I'm sure that everyone would want to focus on, adverse effects and events. Well, if we're doing a more complex procedure, are we causing more harm by putting in this LV lead? So there was a slight difference, at least in terms of the numerical values, 12.3% of procedure-related events with CRT versus 7.8% in the ICD arm, bearing in mind that some of these patients in the non-CRT arm were having pacemakers upgraded to ICD. However, 0.5% of patients who had a CRT upgrade over the course of the trial had an episode of VT or VF, and bearing in mind these are all being monitored by a device, versus almost 15% in the ICD arm. And that was statistically significant, extremely significant. And I think that likely outweighs any concern about the sort of procedurally related complications, or at least that was the conclusion of the investigators. So to conclude that study, patients with HFrEF and a significant RV pacing burden should be offered a CRT upgrade. This would result in fewer hospitalizations, lower mortality, and potentially also improve LV reverse remodeling. And most importantly, this seemed to be safe and well tolerated, particularly given this very sick population that they actually used in this study. Next slide, please. So, thank you. So I'll focus on a couple of the studies on inpatient diuretic therapy. Next slide. So dictate AHF. This was 240 patients that were randomized 1-to-1 in a trial using a baseline intravenous furosemide escalation algorithm based on urine output. One arm got dapagliflozin 10 milligrams OD, started on admission, the other arm did not. And this was to measure how did dapagliflozin affect the diuretic efficiency, basically. Does it make people pass more urine? Primary outcome was this efficiency, how much weight do they lose per 40 milligrams of IV furosemide, and then they also looked at how much do people have worsening heart failure during their inpatient stay, 30-day readmission, and also length of stay. Next slide, please, Simon. Excuse my cough, by the way, recovering still. So looking at their sort of primary outcome, it didn't quite meet statistical significance, but if you look at this right-hand red graph, there is a trend towards an increased sort of efficacy and sort of power of the furosemide when dapagliflozin was on board, with more weight loss per 40 milligrams of furosemide in the dapagliflozin arm. And then the next slide. And I think looking at this much more nicely demonstrates it. So weight loss was about the same in both groups because they were aiming for a certain amount of safe weight loss during inpatient stay. But the amount of furosemide required in the dapagliflozin arm to achieve that weight loss was 560 milligrams IV on average, whilst in the usual care arm, just IV furosemide, 800 milligrams. So that's quite a drastic difference. And then if we go on to the next slide, and this mapped out as a higher proportion of patients by day 5 being ready for discharge and off IV diuretics, 52% in the dapagliflozin arm versus only a third in the usual care arm. This was significant. Next slide, please. So, adverse effects, there was no worsening renal function, no worsening hypoglycemic events, no worsening hospital readmissions post-discharge, and there weren't any difference in worsening heart failure episodes during inpatient stay between the two groups. So, dapagliflozin added early in acute IV diuretic regimens appeared to be safe and effective. Early initiation may reduce total diuretic dose required to achieve decongestion, time required to decongest, and therefore reduce hospital length of stay. However, this is a small study. I know that some people will be doing this already. I know that Wilfred Mullins, who's the big diuretic man from ESC, a fantastic presenter, advocates initiating dapagliflozin on many patients as soon as they arrive with acute heart failure. This is not something that I've seen myself, at least, being done widely, but something to be discussed perhaps afterwards or considered in the future. Next slide, please. So another study, PUSH-AHF, looked at whether or not measuring routine and regular urine sodium would have a benefit in helping us to adjust diuretic dosing. And they measured the urine sodium in one group of patients and didn't in the other, and used a normal IV diuretic escalation protocol. And if you look here, they're doing this at 2 hours, 6 hours, 12 hours, 18 hours. Realistically, this does not look to me to be feasible in any UK NHS setting, but I think it's useful as a sort of scientific basis. Can we use this in the future? Can we use it to, affect how we're diuresing? 310 patients, and based on the sodium readings in the urine, they would adjust their diuretic protocol, increase if they weren't getting enough natriuresis to try and guide better diuresis, really. And they looked at 180-day mortality and heart failure hospitalization. This is the sodium and excretion diuresis. Yes, it did look like in the blue arms they did achieve more sodium excretion when they were measuring the sodiums and increasing. That makes sense to me. And they did also achieve an overall improved diuresis at both 24 hours and 48 hours, which did reach statistical significance. And on to the next slide. So interestingly, there was a significant difference in in-hospital death found here. So the sodium guided, so urine sodium guided therapy, 1.4% of patients died during inpatient stay. This was HFrEF and HFpEF patients. That was 7.5% of inpatient deaths in the non-sodium guided arm. So perhaps more aggressive diuresis being allowed by that. However, the two curves, having separated initially, then meet again later on at 180 days. So no significant difference down the line. However, this is replicated in a number of the acute diuretic studies, which struggle to prove improvement in long-term outcomes. Next slide, please, Simon. So no significant increase in worsening renal or cardiac events. So conclusions, at least my views, Measuring urinary sodium levels to guide response to diuretic dosing may have some benefit in guiding in-hospital diuresis and appear to be safe. And data suggesting reduced in-hospital mortality is definitely of interest. Is it because they're diuresing more aggressively, more thoroughly to decongestion? However, it didn't affect things in the long term, but my view is that applying this in the UK context is really very difficult. However, using spot urinary sodiums to guide diuresis is perhaps growing in fashion at the moment as well, and has demonstrated some use. Yes, slides will be available afterwards as well. I realise these are very heavy data slides, but my intent was that someone could look through them subsequently. Next, so then this is just a couple of interesting bits. I'm going to try and, I don't know how much time I've gone through, but I'll rattle through these quickly. So very interesting one. So next slide, please, Simon. The Quest study, I missed this, and I didn't actually hear anyone saying this. So this is a drug called Chilichanshin, which I sort of practiced saying before I came on here. It's a blend of Chinese medicine, which has been used in the East, in Asian medicine previously, and this was added to patients already on a high dose. So basically, Entresto, 50% of them were on a huge amount on MRAs, huge amount on beta blockers, and it managed to achieve a hazard ratio of 0.78 for heart failure hospitalization and increased mortality, which is remarkable. That matches many of the drugs we're using as 4-pillar therapy. They didn't add it on with DAPA as well, 10% had it as well, but I think this is a remarkable finding in a very large study of 3,100 patients. So it'll be really interesting to see how this is developed upon in the future. Next slide. So I'm sorry, next slide. Yeah, thank you. So then, and Dr. Aaron Wong, who's a heart failure specialist from Wales, presented 44 patients of his and his teams from Bridgend, which is their early sort of outpatient sodium, so basically Lokelma database, or their potassium binder database, and it demonstrates some of their early results after 2 or 3 years of collecting data in optimizing GDMT. Just looking at this, they went up from 52% of MRA up to 89%. 100% of patients on an ACE, ARB or ARNI at the end of it. 4-pillar therapy doubled from 32 to 64%. And on the next slide, if we could, Simon. And I think this is really amazing data, which is a shame it's only a sort of single center case reports, but LVEF on average before addition of potassium binders, 29% up to 36%. This is in a cohort of patients who've had their GDMT reduced due to hyperkalemia. 67% of patients had an 800 drop in their NT-proBNP, and down at the bottom, percentage of patients who'd had a heart failure hospitalization for decompensated heart failure, 30% in the period before starting on this project, down to 11%. So I think this is really remarkable, shows the potential impact that potassium binders may have to help us with GDMT optimization in the future. And then final slide, it's just a few conclusions which I've already summarized, and I will stop there and obviously hand back to Simon.
Thank you very much, Matt. That was a great whistle-stop tour through some of the trials. And just to answer, this is all recorded as well, this webinar, so it will be going on the BSH sort of website sort of page, so you can go back and look at it. So yes, slides available, but actually you can go back and hear the sort of Vicky and Becky and Matt talk about and going through the things. So I'm going to open this up to any questions. So if you have questions and the chat's working, please, or if you just want to sort of come in, and if you've got anything burning questions, come in. Otherwise, I'll start off because I haven't said nobody's jumped in. So for me, I think there's lots of great work going on. We've got lots of therapies that are coming out. And across the board, Becky talked about the importance of the MDT collaborative working. We know our sort of 4 pillars that we're aiming for. The real challenge is how we're going to get these therapies to these patients. So I'm going to open that up to our 3 speakers and say, how are we going to do that? Because, I like strong ATF. I'm very aggressive. I believe that everybody who comes in with acute heart failure should go home on the 4 pillars if they are suitable, and I can do it because I'm going to be controversial. I know that it's a challenge for things to be titrated and started in primary care. So here we go. That's my first question to you 3.
I mean, I agree with you. I mean, I didn't realise I worked in such a forward-thinking department until I started seeing all this and realised how many of them were just whacking everyone on. I kind of grew up in heart failure, watching them do all of this, so it wasn't new. And I find it fascinating, and in some ways, by being so blasé, it makes it easier because they are so blasé. They just do it, and everyone stops arguing. Certainly in hospital, it's so easy. We can measure their bloods every day. We can measure their blood pressure 3 times a day. Getting that titration in an acute patient's easier. Outpatients are harder because we're relying on patients, getting people in through and fast. But there's some great examples of this going on up in Glasgow. I know Ian, one of the pharmacists up there, he's absolutely getting through. I think they'd manage it in 6 weeks, and there's some other published data on it. So it's very doable. I think it's just the will of the people.
Go on, Becky. I'm sorry, Matt, come on.
Yeah, so I think it's, well, from our perspective, very fortunate to work in a really well supported and very, big heart failure MDT, my current trust in North London. But I think that the resources that we have available to us are not realistic for many trusts across the country, and particularly in previous trust DGHs that may not have a specific heart failure team. And so, yes, having 2-week post-discharge follow-up clinics really allows this. Having inpatient heart failure teams that can review patients regularly really facilitates early introduction as well. But actually, a huge number of our heart failure patients are being looked after by non-heart failure specialists in their inpatient stay and also subsequent to that. And so there is a huge part, I think, for sort of education of our general medical colleagues, that it is a good reason to keep someone in for an extra day if it means that we can get these pillars on board. I realise that education is really tricky to address, but I think that, in an ideal world, we'd be able to do it ourselves with everyone. But I don't think that every patient in the UK has the luxury of a heart failure specialist overseeing their care in hospital and immediately afterwards.
Yeah, I certainly think from a community setting, we need the investment in heart failure nurses and heart failure pharmacists in the community to help with the additional titration in the community. It's difficult to meet that need and to do it quickly when there are so many patients to see. So it does help having patients discharged on all 4 pillars, and then we just need to up titrate in the community. But certainly, we need increased investment in the teams to get that done.
Excellent. So I've got a couple of hands up, which is great. So I'm going to go from the top. So Abigail, I saw your hands up. So you come in with your question.
Yeah, hi, good evening. I'm a community heart failure nurse in the South Lakes, and I was just going to build on what Rebecca was just saying there. Not only do we need the funding, but I would say that the education to build confidence within our community practitioners would be useful, because a lot of the time my job is reassuring people that what we've done is appropriate, and that dip in renal function is acceptable, and that they have tolerated it, that blood pressure is okay. So a much wider education to build confidence generally would be useful.
I completely agree.
Yeah, I was going to say, I completely agree. In fact, but it's not just in the community. Our ward pharmacists who are brilliant. I had a conversation with one of them today about just carry on giving the Entresto, that he's not falling over and his renal function is stable, and that's what the patient needs. And it is that reassurance. And
Simon, you've been muted. I don't know about anyone else. I can't hear you anymore.
I can hear you though.
I can't either.
It's all right.
You're right. I was muted. Somebody muted me. All my heart failure nurses want to do that all the time. I can see Paul's got his hand up. So Paul, good to hear from you. Go on.
Thanks, Simon, and thanks to everybody that presented. I was just going to follow up on what you were saying, and I suppose the question is, do you think there's any chance that NICE might sort of pick its heels up and produce an algorithm that looks like the modern treatment of heart failure to help discussions with commissioners when you're trying to argue for these sorts of services? I mean, obviously we can do everything we can as you've described, but if you're up against guidance that sort of looks about 10 years old, and then we're talking about new therapies coming online that we'll be keen to push out as well, I think we're really going to struggle unless that happens.
So NICE are recruiting at the moment, so that normally indicates that they're about to start doing something. Whether I can guarantee you, having done a NICE guideline, it won't be as pretty. But if it aligns, you'll be all right.
Vicky and I actually a couple of days ago had an interesting conversation about the ESC guidance. So I'm gonna Vicky, I'm gonna let Vicky expand on this, because you had some interesting thoughts about some of the approach to it, didn't you? And I think it'd be useful.
The ESC heart failure guidance I absolutely adore. This was the latest guidance that came out, which was the ESC diabetes guidance, and I think as a specialty, we need to look beyond our own doors, because I as somebody who worked in diabetes for 12 years, I have a great love for other things. And if you look at some of the KDIGO guidance, which is the renal guys, and the EASD, which is the European Diabetes guys, they've got some beautiful guidelines. And the EASD guidance is phenomenal, because it is a true CVRM. It doesn't align just on glucose. It really focuses on your cardiovascular risk factors. It really focuses on your renal measurements, your urine albumin creatinine ratios, and how you treat them all together. The problem I have with the ESC cardio guidance is pretty much its algorithm is, this is cardio safe, this is cardio great, this is cardio safe. So things like insulin, for example, it says, well, you know, it's all right for the heart. If you're working in diabetes and someone needs insulin, don't really care about their heart at that point in time, because their glucose is through the roof and they might have a DKA, or they might come in with HHS. And that balance, I felt personally, and this is very much my personal opinion, was really missing from the latest ESC cardio guidance. And I went to multiple things to listen through this, and it was cardiologists writing something for other people, and I found that frustrating. So I think we all need to start looking at other guidance. I appreciate when you're looking at formulary, it gets really tricky, because I have the same battles in my own part of town. One of the issues that heart failure are going to have is that if it's in a technology appraisal, NICE don't incorporate it into a guideline. And it's the fallacy of the way that NICE was originally designed, in that they have different update things. So the fight to get in the new type 2 diabetes guideline, originally they all the SGLT2s were in a technology appraisal, and they didn't want to include them in the new type 2 diabetes guideline, because they weren't in the original one. So there's a lot of fighting going on. I'm hoping that NICE, if they do a new heart failure, will really kind of up their game. And if you look at the evidence, and NICE is, you know, handcuff itself to the evidence, what we're seeing in ESC now will likely come through, because the evidence is pretty much bulletproof. The only issue you'll get is affordability, because ESC do not consider costs. So whether or not they start putting layers in, you know, this is what we've had with the GLP-1s, you know, you can't have it unless your BMI greater than 35. And whether or not by the time they've published, things like the GLP-1s have come out and they haven't considered them. That's our big problem with NICE. So I agree with you that for primary care and for non-specialists, where we're trying to really encourage use, we are up against it. And I don't think we're going to really get past the way that NICE behave, because of the way it's designed. They're kind of sunk in it now, but I think definitely the next update will definitely move us into a much better position to sort of 4-pillar therapy, everyone.
Thanks, Vicky. I think that, you know, we had a long conversation about this, and I think it's true, and I think it really highlights where we are. I recently went to a meeting with our renal team, our diabetic team, and you know, they are so entwined, and how we're going to actually be doing the right thing for all. You know, it's really important how we're going to work that through. I am going to move us on. I've got 3 minutes, and I can see Babak's patiently had his hand up, so I'm going to ask Dr. Naziri to come in. And hi, Babak. Thanks for joining us.
Thank you. Hi. Thank you for the presentation. Very well summarized and presented. Fantastic. Just wanted to talk about the DGH point, which was raised, and not having heart failure team in DGH. I think in this day and age, that should not be an excuse. We need to very much push for every DGH to have a specialized heart failure team. I'm very privileged to work in a smaller DGH, Simon knows very well, who I think we are doing very well with our resources and reaching out, and we have a good network with the communities as well, with pharmacists and community pharmacists and GPs and everything. So it is doable in smaller DGHs as well. And I think if there is a DGH in the country which doesn't have a dedicated heart failure team, that I think that's from the society point of view, we have to we have to push for that this is not acceptable. This should be rectified. So yes, it does work in DGHs as well.
Well, so I'm going to say, as sort of Barack and I work together and like you say, I think there are some fabulous sort of DGHs, fabulous community teams, and actually you very nicely have set me up for the, hopefully at BSH. Well, I know at BSH there's currently been the mapping project looking at cardiac services across the heart failure services across the UK, and Jane Masters is going to be presenting that data at BSH, the provisional data, and we're looking to write that up. And I think this is so important because that sort of ties into my first question around, actually, it's great having new therapies, it's great having all this evidence, but when we think about our heart failure patients, and are they all getting optimal therapy? Are they all getting, and actually, then this work is so important, and it's what we're all here to do, is to get the patients on the right therapies and correctly treated, and that's why we need we need these webinars, we need to be developing our services, we need to be challenging commissioners and all of these things. So I think great question, and actually we're going to have we're hopefully getting more information coming out around what services look like, so we can challenge our commissioners, so we can challenge about how we develop the services going forward. Now it's 1 minute to wait. I'm going to draw it to a close. I would really like to thank all three of our speakers tonight, Becky, Vicky, and Matthew. I think it was really great, a really great overview. I wish I'd been able to get to ESC when everybody else has, and because I agree. I think it's a great meeting, it's a great conference, and you always, sometimes when you end up in the rooms you don't expect to end up in, you learn the most. And but thank you again for everybody for sort of presenting, and thanks everybody for joining us. Go and have a glass of wine, and hopefully we'll be seeing you, I can't believe it, in about 2.5 to 3 weeks. I can't believe we're nearly at another BSH annual meeting, so look forward to seeing you all soon. If Matt, Vicky, everybody stays on while everybody leaves, and then we'll just we can stop recording now.